Hi everyone, welcome to our fifth REACH webinar, which is a non-promotional series of educational events designed to educate and engage rheumatologists, but also other specialty physicians as well with respect to immune-mediated inflammatory diseases. Today, our session is entitled A Representative Future, Precision, Algorithms and Innovative Medicine. And it's a real pleasure of mine to be joined by two really eminent leaders in the field. So we first have Dr. James Lee, who is a clinician scientist and group leader at the Francis Crick Institute. He's also an honorary consultant gastroenterologist at the Royal Free Hospital in London in the UK. And Dr. Maya Hightower, who's a consultant and advisor and former executive vice president, chief digital technology officer at the University of Chicago Medicine and former CEO of Equality AI. And I am Pooja Mehta, a rheumatologist doing a PhD in ILD at UCL in London. So the outline of our talks this evening is going to be first a talk by James on discovery and precision medicine and genetics with a short Q&A of about 5 minutes. And then we'll have Maya giving us a talk on AI in precision medicine, ensuring equity and minimizing algorithmic bias. These are our disclosures.
Great, thank you very much, Pooja. Very nice to join you all this evening. It was this evening from London. I suspect it may not be this evening in various other parts of the world. So, as I say, my name's James Lee. I'm a group leader in London at the Francis Crick Institute, and I'm a gastroenterologist. And my lab particularly interested in trying to better understand how autoimmune and inflammatory diseases work from a perspective of genetics. But I've got quite a long background history in terms of precision medicine, so it's an interesting talk to give to sort of bridge my sort of current and former lives. So, we face a really big problem in looking after immune-mediated inflammatory diseases, and this is true whether you're talking about ankylosing spondylitis or rheumatoid arthritis or inflammatory bowel disease, which is what I look after. And it's nicely illustrated on this slide, and this is just the change in the incidence of a whole range of different immune-mediated diseases just over the last 20 years. And what you can see is that the vast majority of these bars are to the right of the dotted line, which means the incidence is getting commoner. So we are seeing more and more of these diseases. In IBD in the UK, it's been estimated that by 2028, we'll be dealing with double the number of patients we were dealing with just 20 years earlier. So this creates a huge problem, and it's very much becoming a sort of global epidemic in sort of autoimmunity. And the reason it's a problem is illustrated on this slide. So this is data from ulcerative colitis, but I am sure that I could have gone and got similar data from any of the different diseases that the people on the call will be looking after. And just to walk you through this, on the left-hand side of this dotted line are the remission rates, the early remission rates for a whole series of different drugs in the pivotal studies in which they got approved. And on the right-hand side is the remission rate in the placebo arm. And the reason for putting this slide up is just a very simple takeaway, is that for the majority of the drugs we use, they do not work early and effectively in the vast majority of our patients. So, you're looking at early remission rates of somewhere between about 15 and 30%, which means that somewhere between 70 and 85% of our patients are not getting better as quickly as we want them to. So what are we going to do about this? Because this is a major problem. We're having more patients coming through the door, and we don't have treatments that universally work for everybody. So one approach is that we could think about ways in which we could use our existing treatments in a better way. And that is something that people have started to do over the last few years. This is an illustrative trial. Again, it was done in inflammatory bowel disease, but there will be similar studies elsewhere. So this was actually a relatively simple study, and the idea was that you would randomize patients to one of three different arms. They would either get a P19 inhibitor that blocks IL-23, they'd get a TNF inhibitor, or they'd get both. And what they nicely showed was that if you give patients both treatments, they have higher remission rates than if you give either of these drugs on their own. Now, that might sound like it's obvious, give more therapy and more people get better. But I think there's a few things that we need to think about if we are to implement this in our practice. The first is, how do we do it? People have thought about, well, maybe we start with both, or maybe we use one after the other, or maybe we start with one and then add the second one in if things aren't going so well. And what happens when the patients then get better? Do we drop one of the therapies? Do we keep them going? Or maybe we just use pulses of the second therapy as and when needed for the patients. And all of these are sort of live discussion points, and these are things that are being addressed in ongoing trials at the moment. I think, when we think about the sort of result that I've just shown you, where you have two drugs and giving the two together works better than giving either alone, there's a couple of obvious takeaways, and then there's perhaps some less obvious takeaways. Most obvious takeaway is that two drugs is better than one. And I don't think it's a stretch to think that, the next thing we will be thinking about is maybe three might be better than two, and maybe four might be better than three. Um, and that may be something that I think we're going to see ongoing over the next few years. The other thing, which is maybe a slightly more nuanced point, but I think it's important, is what this tells us is that different patients are responding to different therapies. Because if there was just a core subset of patients who would respond to anything they're given, and a refractory subset of patients who are not going to respond to anything, then actually giving two drugs won't make a difference. You'll have exactly the same remission rates because the responders will respond and the non-responders won't. The fact we increment, the fact we get better responses, tells us that there are some patients who need one drug, some patients who need the other, and perhaps there's some patients who need both. And I think that again is an interesting question, because are we talking about 1 + 1 is 2? So we have an additive effect. And so you're simply, the people who would respond to the TNF will respond if they get both. The people who respond to the P19 inhibitor will respond if they get both. And by adding that together, that's why it's better. Or maybe there's going to be a situation, and we don't have examples of this yet, but maybe there would be a situation where actually people who get both drugs will respond where they wouldn't have responded if they've got either of those drugs alone. And is there some sort of synergistic effect that we perhaps might be capturing? So what all of this is leading to is the idea that we have increasing numbers of drugs, we have an enlarging patient population, and what we'd really like to be doing is thinking about how do we match patients to the treatment that is the right one for them. And that means not just the drug that they're most likely to respond to, but also the drug that's least likely to give them side effects or other complications. And so what this would ideally look like is a way in which we could identify upfront which is the right drug for each patient, and then we could allocate them to that right drug. And it might be individual drugs, or it might even be combinations of drugs. And what all of this is effectively talking about is precision medicine, the idea that you give the right drug to the right patient at the right time. But the problem is, whenever anyone talks about precision medicine, there will be people on the call thinking there's a higher chance that I'm going to see pigs flying around the room by the end of this talk than that we're actually going to see precision medicine being implemented in our lifetimes in these diseases. Because we've been talking about this for a very long time. Barack Obama launched the big precision medicine initiative in the US, and that was quite a long time ago. And yet we still are not in a position where, for at least many people, we're actually seeing this come to bear. Or are we? Because actually there are examples of precision medicine that we're already doing. It's just that we tend to think of precision medicine as being some sort of flashy, sort of sexy thing, but actually maybe actually a lot of what we're doing is already precision medicine. You could argue that whenever someone has a blood transfusion in a hospital, that is precision medicine because you are matching that patient to the right unit of blood based on, their ABO blood type. And in fact, in inflammatory bowel disease and other immune-mediated inflammatory diseases, there are elements of precision medicine that we're already using. When we use thiopurine, so azathioprine or 6-mercaptopurine, one of the things we're all familiar with doing is checking the TPMT. And we're doing that because that will enable us to give the right dose to make sure we minimize the chance of that patient getting side effects, or in some cases, not giving the drug at all if these people are TPMT null. And there's been some interesting genetic studies recently showing that actually NUDT15 and polymorphisms in that gene are arguably even more important, particularly in East Asian populations, such that now there are places where you can send off your DNA for your patient at the time, and they will check for all the relevant polymorphisms in order to give you an understanding of how likely that patient is to get side effects and whether or not they should be given the drug, and if so, at what dose. The other thing that we've recently started doing in inflammatory bowel disease is thinking about some of the things that might predict immunogenicity. So particularly with anti-TNFs, we often see the development of antibodies against those drugs, which then sort of sequester the antibody and mean that we can no longer use it. And we showed a few years ago through work led by Tariq Ahmed in Exeter that there is a genetic predisposition to this. And that genetic predisposition is within the HLA region on chromosome 6. And it seems to associate with the carriage of this HLA DQA105 allele. And to show you what this means in practical terms, the filled in line here is the incidence. This is the development of anti-drug antibodies. So as the people drop down, it means they're developing these antibodies. This is the development in people who are on an immunosuppressant, which we know reduces that chance, and do not carry any copies of this risk allele. This is the dotted line is the people who are not on immunosuppressants and don't carry any copies. If you then look at the effect of actually carrying these alleles, this is then people who are on immunosuppressants but carry one or more of the risk alleles. And you can see that they look like the people who do not carry the risk allele and are not on immunosuppressants. And if you are unfortunate enough to carry one of these copies and you do not get given immunosuppressants, it's almost 100% chance that within the first year or so, you will develop antibodies against the drug. And the nice thing is that because these are all genetic tests, people have started to think about whether or not this could be put into practice. This is just to illustrate that actually this is true irrespective of which of the TNF inhibitors were used. So this is what this might look like. This is actually work done in the Netherlands with the idea that you take your IBD patients and you very simply genotype them for either TPMT, the NUDT15, or the HLA allele. And that will enable you to stratify these patients into their relative risk of being, should this patient be given a thiopurine or should they be given a TNF? And if they're given a TNF, do they need to have a thiopurine alongside it? And actually, you don't need to genotype very many people in order to start seeing benefit. These genotyping tests are very cheap. And so actually, people are already starting to use these genetic passports, and I think this will continue to grow. But what people are really interested in, and that this comes back to the point about identifying the right treatment up front, is finding out which of the treatments we have are our patients most likely to respond to. And the simple answer is we don't have those predictors at the moment. There are some very large studies being done both in the UK and in Europe. One is IBD Response, led by Chris Lamb in Newcastle, and Methylomic, led by Gerda Hans in Amsterdam, about trying to find biomarkers that would enable us to predict the right treatment based on the likelihood the patient is going to respond. So why all of a sudden are we now able to do these sorts of studies? Well, it's largely driven by the advances in technology. So not that long ago, people were doing linkage studies and having to pick their favorite region of the genome in order to investigate. These linkage studies were, largely hopeless just because, we weren't very good at picking the right regions. But actually, now that we can interrogate the entire genome, and in fact, more than that, we can look at the epigenome and the transcriptome and the proteome and so on and so on and so on, we're actually in a position whereby we can start in a hypothesis-free way identifying parameters that might correlate with things like treatment outcome. And that's great, and it's an important advance that's enabled lots of sort of developments in this sort of space. But there is a big but. And the big but is that these sorts of data sets generate vast amounts of data. And the problem with having vast amounts of data, particularly when you have, say, a binary outcome like response or non-response, is that you will find things that correlate, but actually that's just happening by chance because you've got so many variables, you will inevitably find things that correlate. So what do I mean by that? Well, here are two data sets. If the red line was the level of a particular metabolite in the serum, and if the black line was the chance of responding to a particular drug, you say, well, look, this is great. You found a very clear biomarker that clearly can predict over multiple years of multiple patient cohorts the chance of responding. But actually, that's not what these lines are at all. In fact, these lines are entirely spurious correlations. The red one is the number of worldwide non-commercial space launches, and the black one's the number of sociology doctorates awarded in the US. So of course, this is completely implausible. There's no way these two variables could ever be linked. But when you have enough data sets, you will find correlations that are entirely spurious. And that's a big challenge in developing biomarkers because you've got to try and sift out and find the true signal amongst all the noise that you may be seeing in your data. And that's part of the reason why actually biomarker development has proven very challenging. This is in fact, we tend to think of oncology as the one area of medicine where biomarker development has been a success. But this was an editorial based on biomarker attempts in oncology from 12 years ago. And I just want to highlight that, we all look at oncology and think that that's the exemplar for how to do this. But this is saying that despite all the promises that biomarkers can improve the diagnosis, prognosis, prediction, management, and outcomes of individual patients, the yield of successful biomarkers with unquestionably favorable health impacts has been extremely limited. And in fact, biomarker failures are rather than the rule. So I think the one way in which we can get around this is that when we are developing biomarkers, we have to follow actually a relatively straightforward set of rules. We need to make sure that we have adequate validation in independent cohorts so that we can tease out what's the real signal and what's the value of that signal, as opposed to the things that might be noise. Of course, that's difficult to do because it involves recruiting entirely new cohorts, and there is an inherent risk that your biomarker won't validate. Of course, many times people will just want to get these things published and move on. But I think increasingly we need to hold, we as reviewers and editors need to hold people to account to say that this needs to be done properly.